welcome to this session, Strengthening the Immunotherapy Paradigm in Advanced Squamous Cell Anal Cancer. So welcome. We have a really interesting and exciting mix of talks, as well as questions, so interactive discussion, and we've got questions and answers at the end. So I'm going to start by giving you an introduction. I'm actually going to stand. So these are our panelists tonight, myself, Sheila Rao, Kristen Ciombor, and Professor Stefano Kim. So first of all, thanks to Peerview and the Anal Cancer Foundation for providing this session, and to Insight Corporation for providing the educational grant. If you've not already done so, please complete the pre-event survey and look out for additional polling during the presentation for you to participate in. Please do submit your questions and do that sort of from now on in, and we will try and answer them during the question and answer session. And in-room learners, use your personal device to scan the QR code or on the following slides to respond to the polls. So this is a QR code that you can scan onto your mobile device. And you can visit us at peerview.com. There we are, / with the details there. And you can view all the slides and practice aids, and you can also download these after the event. You can also join on X, and obviously you can send an email live as well. So what are our goals for today? Well, we want to try and review the latest clinical trial evidence and guideline recommendations supporting the use of immunotherapy for the management of this disease. We want to try and develop some personalised treatment plans based on guideline recommendations and the latest clinical trial evidence. And we want to try and integrate team-based strategies to address the various nuances of treatment delivery with immunotherapy platforms, including care coordination, patient consultation and engagement, and immune-related adverse event management. So, as I said, my name's Sheila Rao. For those who don't know me, I am a consultant medical oncologist in London with a specialist interest in anal cancer. So, if we want to start with a little introduction, so the incidence of anal cancer, less than 1% of all cancers and less than 3% of all GI cancers, but the incidence is increasing worldwide, particularly in Europe, the USA, and Australia. And there's been a profound increase, and I think we're all seeing this, in incidence of younger age patients between 45 to 65. And we're seeing more advanced stages at diagnosis. So in 2001 to 2015, 30.5% to 44.6% in men, and 33.9% to 47% in women. And some of that's associated with increased mortality. And in terms of advanced disease, about 15% will present de novo with stage 4 disease, but then somewhere around 20 to up to 37% will have recurrence after localized disease. So that's quite a proportion that will eventually have advanced disease. So the majority of squamous cell carcinoma, and obviously there is a really strong association with HPV, or human papillomavirus, 90% related to HPV-16, and notably 90% of HPV-positive disease is detectable by liquid biopsy with circulating tumor DNA. So it's a relatively neglected disease, particularly in the advanced setting, and despite its incidence increasing and this being endemic, it's been relatively understudied till fairly recently. Obviously, HIV is a really important amplifier, and so you see a much stronger correlation of this disease with HIV. And the primary treatment's chemoradiation, but relapse after this treatment is more common now, and standard of care treatment in the primary setting has certainly not changed for a very long time, and even in the advanced setting until recently had not really changed. And for patients who progress or who relapse, or who have de novo metastatic disease, the prognosis is still relatively poor, and obviously these patients, the quality of life is quite diminished. This is the Anal Cancer Foundation, which is a superb resource that very fortunate to have. They have a number of different guidelines, so they also have webinars, but they have a patient guide, they have patient conferences, and so anyone that wants to sort of look at this in more detail, there are QR codes there, but this is really a very patient-friendly, very useful resource that I think sort of in the US you're certainly very, very fortunate to have. And I'm going to now introduce Stefano Kim, who is going to talk to us about integrating IO in advanced squamous cell anal cancer. Stefano's also got a specialist interest in anal cancer and has published heavily in this disease, so I'll hand over to him.
Thank you, Sheila. Thank you very much to the organizer and peer review. It's my pleasure to be here sharing this session with you all and with my colleagues Sheila Rao and Kristen Ciombor. So we're going to start with the rationale for PD-1 inhibitors. As you know, as Sheila just said, 90% of patients with HPV positive is related to HPV 16 genotype. And the oncogenesis in this disease is very homogeneous, particularly in anal cancer, more than other cancer, probably. And it's related, as you know, to oncoprotein E7 and E6, which inhibit RB and P53 in this inhibition and stimulating the tumor oncogenesis. What is little unknown is that E6 also activates the promoter of human telomerase, and this is present in most of the anal cancer and leading to the tumor immortalization. In this study that we have performed, we can see that immune tumor response against HPV E6 or E7 or against the human telomerase is related to prognosis at baseline and after chemotherapy, suggesting that there is an immune anti-tumor activity and which is correlated with prognosis. Maybe this is the rationale, strongest rationale for the immunotherapy. As you know, that immunotherapy, especially the anti-PD-1 antibodies, are recommended regimen in second line, is the only prospectively validated regimen. And here you have the NCCN guideline suggesting that immunotherapy could be a possibility in second line in patients refractory to first-line chemotherapy. So the first study was with nivolumab, which have shown very encouraging results in a relatively small phase 2 study, showing an objective response rate in 24% of patients, including 5% of complete responses, median PFS of 4 months, and duration of response of roughly 6 months. However, in later study, larger study, phase 1, phase 3, demonstrated that probably this was overrated, and now we assume that objective response rate is between 10 to 15% of patients. Like this one, this is pembrolizumab. You have 2 different studies, the phase 1 and phase 2 basket study, and altogether they have 136 anal cancer patients refractory to chemotherapy or radiotherapy, and they received pembrolizumab. And we can see that objective response rate in this larger study is 12%. Okay, only the half of what we have seen with nivolumab, but I think this is more likely and related to the real-life data. The complete response rate was observed in 4% of patients, and they were exclusively PD-L1 positive patients, median PFS of 2 months, and duration of response of 8 months. More recently, we have seen this retifanlimab phase 2 study. This is our larger study with 94 patients. And you can see that even though they didn't reach the primary endpoint of objective response rates. It's similar to that what we have seen with pembrolizumab with 14% of objective response rate. Only one patient presented a confirmed complete response, PFS rate 2.3 months, and the duration of response was larger with 11 months. Okay? And altogether, today we have around 300 patients who received prospectively anti-PD-1 or PD-L1 antibodies. And we can say that around 10 to 15% of patients benefit of long duration response to immunotherapy as monotherapy. Here we can see the objective response rate in all these trials was 13.8%, 3% of complete response rate, median PFS between 2 and 4 months, and duration of response 6 to 12 months. So the first question, which of the following accurately describes the main finding of the Podium 202 trial evaluating retifanlimab for progressive anal carcinoma? Please respond. Number 1, retifanlimab significantly improved overall survival compared to chemotherapy. Number 2, retifanlimab met its primary endpoint of objective response rate, demonstrating a promising clinical response. Number 3, the trial showed that retifanlimab significantly improved PFS, but did not meet its objective response rate endpoint. Number 4, retifanlimab failed to demonstrate any clinical benefit in patients with recurrent or metastatic squamous cell carcinoma with no significant changes in objective response rate or PFS, and you're not sure. Okay, then 50%, okay. Number 2, and I'm not sure, okay. Its primary endpoint, okay. In fact, the primary endpoint was objective response rate, and they designed the trial after nivolumab, phase 2 trial with 24% of objective response rate. And they did not reach this objective response rate because it is not related to the real-life data. Now we assume that objective response rate is between 10 to 15%, and retifanlimab this as well as pembrolizumab, and I think this is more accurate today. So there is a response, a durable response, and in around 10 to 15% of patients. So how can we improve this data and immunotherapy as monotherapy? Of course, there are combinations, well-known ipilimumab to anti-PD-1 antibody, or with the addition of anti-angiogenic treatment, bevacizumab, or anti-EGFR, that they are rationale for squamous cell carcinoma. So first one is a randomized phase 2 comparative study, nivolumab plus or minus ipilimumab. They include 100 patients, randomization 1:1. And even though there is a numerical benefit in PFS, objective response rate, and overall survival, they did not reach a significant difference in its primary endpoint, which was PFS. Okay, 3.7 months versus 2.9 months, and P 0.16. And we can see that toxicity was higher, including one toxic death for grade 5 pneumonitis. So maybe bevacizumab, this is a single-arm phase 2 basket trial where 20 patients with anal carcinoma were included. We can see that PFS is correct, as well as overall survival. However, it did not reach its objective response rate, which was only 10%. Okay? And there was a significant toxicity with a grade 5 bowel perforation in one patient. So adding anti-EGFR may be the solution. This is a non-comparative randomized phase 2 trial, a 60-patient, one-to-one randomization. The PFS was numerically better, as well as objective response rate, which was the primary endpoint, and the overall survivor. However, I think, this is my personal opinion, there is more like additional effect and not synergic effect, since the 12-month PFS rate was less than 15% for both arms. Okay. And how can we improve this treatment? So, as I said, that probably the tumor vaccines in this disease is very important, because there is a tumor antigen, a specific tumor antigen, which is E6 and E7. As you know, it doesn't exist in a normal person, or including in non-invasive HPV disease, that this can be naturally a target. The other target is human telomerase. Okay? So this study performed the combination of nivolumab and the therapeutic HPV vaccine in 24 evaluable patients. We can see that objective response rate is the highest we have seen, with 33% of patients, including 8% of patients with complete response. And we can see that both patients with complete response and additional one patient with partial response have ongoing response beyond 40 months. Okay? So there is a subset of patients with a high response to this treatment. The other is our study. This is volatile phase 2 study combining human telomerase vaccine and atezolizumab. This is called UCP-VAX, which generated anti-tumor CD4, anti-human telomerase. Okay, this is the design. We associate atezolizumab with 6 injections, and then there is regular base boost of vaccination, and atezolizumab followed by atezolizumab alone up to 1 year. So our primary endpoint was defined as durable objective response, which is evaluated at 4 months. Okay, so if there is a response at 2 months, which is lost at 4 months, they are considered as negative. The durable response was observed in 18% of patients, 8.2% of patients. 44 patients were included. Okay, the recurrence has finished. You can see that among these patients, among these 8 patients with objective response rate, 6 presented complete response. Okay, here we can see 2 examples with a very good response of primary tumor, and including a peritoneal carcinomatosis. Okay? And the 12-month PFS rate was observed in 24% of patients. And as you can see, excepting 2 patients who presented recurrence during the follow-up, other patients remained progression-free. Okay? And the 12-month overall survival rate was encouraging, with 41.5% of patients alive at 1 year. So the take-home message will be anti-PD-1 monotherapy is a valid option in second line. It's the only validated prospectively option after the chemotherapy in first line. Probably the combination of tumor vaccination with HPV vaccination or telomerase vaccination are encouraging, and it increased the benefit probably to 25% of patients. And there are interesting trials ongoing with adoptive T cells demonstrating a durable response in patients heavily pretreated. So the last question for my session will be, assume you are managing a 69-year-old patient with metastatic squamous cell anal carcinoma who progressed on upfront carboplatin paclitaxel. Which of the following treatment options would you select for this patient? Number 1, pembrolizumab. Number 2, nivolumab. Number 3, retifanlimab. What's your preference? Or combined immunotherapy, nivolumab plus ipilimumab. Number 5, nivolumab plus anti-HPV vaccine. 6, modified triplet DCF regimen. Okay? Thank you very much for those who responded modified DCF. As you know, I'm a triple fan. Yeah, there's no difference, of course, between pembrolizumab and nivolumab and retifanlimab. All these regimens are recommended by NCCN guideline. No for nivolumab, ipilimumab today for this negative data, even though there is numerically higher benefits. Okay, it failed for each primary endpoint. And nivolumab plus anti-HPV vaccine, it could be an option in the future, but there is no validating trial yet. Thank you very much.
Thank you, Stefano. So we're now going to move to immunotherapy in earlier lines. So Stefano's given us a really nice précis of the second line data. And now we're going to look at moving this forward into the first line and what that data looks like. So these are the NCCN guidelines currently. And in terms of first line, at the moment we have carboplatin and paclitaxel, and then obviously a number of other chemotherapy regimens there, and carboplatin and paclitaxel and retifanlimab, which I'm going to show you, which is currently category 2B, mainly because the publication is awaited. We have presented the data, but clearly we're waiting full publication. And also we've got DCF, as we mentioned before, in there. So this is the SCARES trial. Stefano presented this last year, or was it the year before at ASCO, wasn't it?
Yeah.
And it was published last year. So this is with a triplet. So this is with DCF, with modified DCF, and this was for patients with advanced disease, metastatic or non-resectable local recurrent, good PS of note 0 to 1, and evaluable disease. And the randomization was 2 to 1 between modified DCF for 8 cycles or modified DCF for 8 cycles with the addition of atezolizumab for up to a year. The primary endpoint was 1 year PFS, and obviously those are the secondary endpoints, and stratification for age, stage, and synchronous metastatic versus metachronous, as well as metastatic versus locally advanced. In terms of the demographics from this trial, so as one would expect, majority were female, majority PS0, so a good population with some PS1, a small proportion of HIV-positive patients, and about 40% synchronous metastatic, as we've discussed, another 37 to 40% metachronous, and there was a smaller proportion of locally advanced disease. And as one would expect, at least half had had previous radiochemotherapy, and a small proportion had had surgery to their primary tumour. So this is a primary endpoint, which was 1 year PFS. And as you can see from these curves, so we've got in red, we've got the DCF plus atezolizumab, and in blue, we've got the modified DCF. And as one can see from these curves, there was not a significant difference. So for arm A, a 1 year PFS of 44.2%, and for arm B, 43.2%. So no difference there. In terms of how that looked on the forest plot, in terms of particular groups, again, what we're seeing on the whole is that there was no particular group that stood out that may have benefited, and it seemed to be across the board that there was not a strong benefit, certainly in that forest plot. So I'm going to now talk to you about the podium study. So this was based on carboplatin and paclitaxel data from the original INTERACT trial, and we developed 2 trials. Kristen will talk to you about the other trial. This was Podium 303 INTERACT 2, which we conducted in the US and Europe and Australia, and there's also a further trial which Kristen will present, which was also carboplatin and paclitaxel as the backbone with nivolumab. So the rationale behind this has already been given to you by Stefano in terms of adding immunotherapy to chemotherapy. And from the phase 2 study, we saw fairly meaningful response and durable response, but still quite limited PFS, 8 months, and overall survival, 20 months, relatively short. And we'd seen, as proof of concept in cervical cancer and head and neck cancer, that adding immunotherapy to chemotherapy and HPV-driven malignancies seemed to prove fruitful. So retifanlimab is a humanized anti-PD-1 monoclonal antibody. Based on the Podium 202 study, which you've just seen, we developed this trial adding it to carboplatin and paclitaxel. So this is a study design. So again, patients with locally recurrent or metastatic squamous cell anal cancer, they were not to have had any prior chemotherapy except for as a radiosensitizing treatment with a radiotherapy, or they could have had neoadjuvant treatment providing it was at least 6 months prior to entry. Again, we allowed patients with HIV, providing that was well controlled, and this was a 300-patient study, and this was a 1-to-1 randomization. We randomized between chemotherapy of carboplatin and paclitaxel 6 months in both arms, and then in one arm we gave retifanlimab intravenously for 6 months additional, so 12 months in total. And in the other arm, we gave placebo, again, 6 months concomitantly with the carboplatin and paclitaxel, and a further 6 months after that. In the placebo arm, patients could cross over after confirmed blinded independent central review of progression to single-agent retifanlimab. And we stratified for PD-L1 expression, region, and extent of disease. Our primary endpoint was PFS, by blinded independent central review, and we were aiming for a hazard ratio of 0.67 with 80% power. And with that alpha spending, we also had a key secondary endpoint providing that was positive for overall survival, as well as overall response rate, duration of response, safety, and pharmacokinetics. And we also did some exploratory endpoints looking at PFS2, patient-reported outcomes, etc., some of which we've not yet fully reported. So this is a consort diagram. We randomized 308 patients, and essentially, let me just take this mouse, we randomized between those two arms, so retifanlimab and chemotherapy 154, and placebo and chemotherapy 154. Of note, in the placebo group, 69 patients crossed over. So you can see here, 69 patients crossed over single-agent retifanlimab. And for both arms, the majority of patients discontinued for progression, and with a small sort of proportion lost to follow-up, but for most patients, it was progression. So in terms of the full analysis set, we have 154 in each arm. So in terms of patient characteristics, again, as one saw from SCARE, majority female, similarly a relatively young age in terms of the median, significant proportion in both arms had radiotherapy, majority had metastatic disease, so over 80%, and about a third in both arms had metastatic disease within the liver. And again, quite a high proportion with PS0, the others were PS1, a smaller proportion with HIV-positive disease. And then the other thing really to note here is that the PD-L1 expression by combined positive score greater than 1 was over 90% for both arms. And as one can see, the arms are relatively well balanced. And this is a primary endpoint, so progression-free survival by blinded independent central review. If you remember, we were aiming for a hazard ratio of 0.67. What you can see here is that we achieved a hazard ratio of 0.63, which is clinically meaningful in this disease. And as you can see from the curves, they're separating, I think quite importantly, relatively early on here. So we do see that separation early on. So the top curve is retifanlimab, the bottom curve is placebo, and there's definite separation relatively early on, with a median of 7.4 for the placebo group and 9.3 for the addition of retifanlimab. But as I say, I think the hazard ratio is the key here at 0.63. So in terms of overall survival, this is an interim analysis. This is not yet mature. And so these data are still interim. But again, the curves are separating relatively early, retifanlimab on the top, placebo on the bottom. At the current time, we're seeing a median overall survival for placebo of 23 months and 29 months but the 95% confidence interval not yet reached with the addition of retifanlimab, hazard ratio of 0.7, trending towards statistical significance, but as I say, these data are not yet mature. Now, those data for overall survival included all patients in the placebo group, including patients who'd crossed over to single-agent retifanlimab. So what we then did was an adjustment for crossover using a rank-preserving structure failure time model. What that essentially does is it recalculates survival as if the patients who had crossed over had not crossed over to give rise to these curves. So on the top here, we've got retifanlimab, and then we've got the placebo-adjusted group. So this is recalculating the survival as if they'd not crossed over, and then this is the placebo group, all comers, patients who had crossed over. And what you're seeing is we're still basically seeing that same trend towards improved overall survival, as I say, interim data, but nevertheless, we're still seeing an improvement and certainly a trend towards overall survival with data yet to mature. In terms of overall response rate, what do we see? So we see an overall response rate improvement from 44% with placebo to 56% with the addition of retifanlimab. And really importantly, though, we also see almost a doubling of duration of response from 7.2 months to 14 months. And a disease control rate in both arms of over 80%, which, again, is quite meaningful. So, in terms of how that compares, we did a comparison. We know we're not meant to do cross-trial comparisons. This is a relatively rare cancer, not that much data. We wanted to understand, was the carboplatin paclitaxel consistent across both these groups? And what one can see from these data quite clearly is that you've got quite a similar demographic population in terms of, from this study, Podium 303, as well as Interact-1, in terms of median age, metastatic disease, performance status, HIV. And then what you're seeing here is also similar. The overall response rate is slightly different, but we can account for this because this was not blinded independent central review. But overall response rate, median PFS, and overall survival are quite similar. So giving us figures now for around 20 to 23 months for the doublet and a PFS of somewhere around 8 months. And those are quite consistent, so quite reassuring. In terms of safety, we did see additional side effects, as one would expect, with the addition of retifanlimab, and these were consistent with previous data, both from previous studies examining both checkpoint inhibition with chemotherapy, so we didn't see any new or concerning safety signals. We saw no loss of HIV, and at the time of data cutoff, almost 60% of patients in the retifanlimab arm remained on study, so there was not any concerning safety signals here. In terms of if we drill down into the specific side effects you can see here, in terms of specific grade 3 or higher, again, no alarming safety signals. We saw some immune-related side effects, as one would expect, including thyroid dysfunction, adrenal insufficiency, and some skin toxicity. So, based on the Podium 303 study, which of the following patient presentations would meet the eligibility criteria for carboplatin paclitaxel plus retifanlimab? Number 1, metastatic or advanced squamous cell anal cancer with no prior systemic therapy. Number 2, metastatic advanced squamous cell anal cancer previously treated with 1 line of therapy. Number 3, locally recurrent or metastatic disease with no prior systemic therapy. Number 4, locally recurrent or metastatic disease previously treated with carboplatin and paclitaxel. Or number 5, I'm not sure, if you want to vote. Okay, what do we have? Okay, that's interesting. So we've still got 26%, I'm not sure. I don't know if that's the wine or whether I haven't been clear enough, but we'll go through it again. Okay, and then we've got 26% no prior systemic for metastatic, 33% locally recurrent, 0 for more than one line. Okay, that's reasonable. So in terms of ongoing plans, so we've got obviously, and I think Kristen will allude to this as well, Stefano has also alluded to this, relatively rare cancer. I think it's really important that we do more translational work to actually understand this disease a bit more and the biology of the disease before we plough on with further trials. So there's quite a lot of work to be done there in terms of correlative work. We want to understand resistance mechanisms. We also clearly want to understand who the patients are that will benefit the most from immunotherapy. And to do that, we need to identify relevant biomarkers. So that work is planned and will be undertaken. But in terms of take-home messages, so this is a rare disease, and I would say that where possible, please try and enter patients into clinical trials. It's the only way we'll move forward here. And actually, you've seen that it is possible to put patients into trials, and we've done some, between us all now, quite large database of clinical trials. So if at all possible, that's the preference. We have a new standard of care in terms of retifanlimab with carboplatin and paclitaxel for patients with advanced or locally recurrent inoperable disease. The immunotherapy, when combined with chemotherapy, appears more effective than monotherapy. We need more work on biomarkers, as we've said. Interestingly, patients with metastatic liver disease do benefit. So although in other GI cancers we're seeing perhaps that liver disease seems to preclude benefit, we're not seeing that here. And obviously, as we move immunotherapy into the first-line setting, we now need further trials in the second-line setting to establish what we would do next. So I'm now going to hand over to Kristen to discuss future directions and other exploratory investigations.
Thank you, Sheila. Yes, so Sheila and Stefano have given us a tour de force of the completed clinical trials, really done over the last decade or so, incorporating immunotherapy in anal cancer treatment. But there's still a lot to understand and to learn, and so I'm going to talk to you a little bit about some ongoing and recently completed clinical trials in this space. So the first trial that I wanted to highlight on the heels of Podium 303 is the ECOG-ACRIN 2176 study. This is a study that recently completed enrollment in September of last year. And this is a study done by the U.S. cooperative groups, really looking at patients very similar to the Podium study with unresectable or metastatic squamous cell anal cancer, and randomizing in a 2-to-1 fashion to carboplatin paclitaxel per the INTERACT-1 versus with or without nivolumab. So patients received carbotax for 6 months, and then for the ones on the nivolumab arm, they continued on monthly maintenance nivolumab for up to 2 years. So this accrued a little over 200 patients. And so the primary endpoint here is progression-free survival with secondary endpoints of response rate, overall survival, et cetera. So we really are looking forward to seeing the results from this study, especially in light of the Podium study and the other first-line studies. So who is eligible? I touched on this a little bit, but really patients with metastatic disease largely had to have RECIST measurable disease. HIV patients, positive patients were enrolled. Their CD4 count had to be at least 200. So this has been a traditionally kind of underrepresented patient population. And everyone always wonders, is immunotherapy safe? But really in well-controlled disease, we've found that has been very safe. And no prior immunotherapy. So the study was designed incorporating an estimated median PFS of 8 months in the control arm, which would hopefully lead to a median PFS of almost 13 months in the nivo arm. So we have also collected samples to look for HPV ctDNA over the course of treatment. And I think that will be an interesting correlative biomarker to look at, especially to correlate with patient response. And that has been done serially over the course of patients' treatment. Another study, which is very interesting, the Spartana study, which is looking, it has a very interesting study design. It's a phase 2, and it's enrolling patients with metastatic disease. Oh, that just shows on there. Sorry. Okay. So the study design here is really patients receive a target lesion radiation. So patients have to be eligible. They have to have RECIST measurable disease, and then they get modified DCF for up to 4 months, and then they are eligible for directed therapy, local therapy. So that could be any ablative therapy, chemoradiation, surgery, et cetera, and then can go on to maintenance spartalizumab. So that will be a very interesting readout, I think, and a very interesting treatment paradigm for patients as well, who we often use various modalities of therapy, especially depending on the type of presentation. So what other studies are we looking forward to seeing results from? Not only, we've talked a lot about first line, second line, and beyond. What about in localized therapy, in localized disease? So the ECOG-ACRIN 2165 study, which was for high-risk patients receiving Nigro protocol, they were randomized to nivolumab or not, and as an adjuvant sort of therapy. So that has completed accrual, and we await the results from that. There are several other studies that are mentioned here. Some are looking at the combination of immunotherapy with chemoradiation. There's an HPV-directed immunotherapy agent, and then an anti-PD-1 in combination with chemo and radiation. So all of these really we look forward to getting results from. And there's still space for more investigation, in particular, trying to optimize the use of immunotherapy in this disease. So some take-homes from the future direction section. As I said, immunotherapy is moving to earlier lines of therapy and disease settings. We have a standard of care for early-stage anal cancer, but as was discussed, not everyone is cured from it, and it is quite toxic. So can we optimize that both for the patient experience, but also to improve cure? I wanted to mention that we haven't talked a lot about NGS and targeted therapies in anal cancer, but I think that's still important to do. The nice thing is immunotherapy does not require a PD-L1 score of any particular number, which is great because of, again, its HPV association. But there can be other options for patients. I just, in the clinic this week, saw a patient with HER2-positive metastatic anal cancer who got upfront carbotaxol and nivolumab, had a beautiful response, and now is receiving trastuzumab deruxtecan because of the tumor-agnostic indication there. So really, I think those are additional options. We also need biomarkers. So as we talked about, there are a lot of people who are benefiting from immunotherapy in particular and other targeted agents, but we really need better predictive biomarkers for response to immunotherapy and for chemotherapy, and also to assess for response to treatment, such as ctDNA or many other biomarkers. And there may be other targets of interest coming down the pike too. So there's a lot of opportunity here, I think, for ongoing investigation. And as Sheila mentioned, this was a traditionally understudied disease because it was felt to be very rare. But I will say that many of these trials accrued very quickly because there is a need and there are patients who are interested in these trials. And so I think the important message is to consider putting patients on these trials because this is how we move the field forward. So with that, I will turn it over to Sheila.
Thank you very much. Now, before I forget, I have to mention, before we do the patient cases, that there is a £50 Amazon, sorry, not pounds, dollars, not in England.
That might be a little better. Yeah.
Sorry, $50 Amazon gift card for the best questions. So do keep them coming because somebody's going to get that $50. Okay? So now we're going to go on to translating science and routine page care. We're going to do some case-based discussion. So I'm going to put some cases up and then I'm going to get some opinions from these two over here. So we'll start with the first case. Actually, I probably need to still stand. So 65-year-old female with advanced squamous cell anal cancer received upfront carboplatin and paclitaxel. Upon follow-up, imaging reveals increased tumor volume and elevated HPV circulating tumor DNA, indicating relapse disease. So I suppose I'll start with, the first question is, how would you approach subsequent treatment selection? Chemotherapy, IO? And given you're considering a second line, let's do the first one first. So let's go to Stefano and then perhaps to Kristen. So what are your factors in terms of considering this and what you do next? Or is there anything else you'd want to know?
So this is a chemorefractory patient. So we have to consider the possibility of complementary treatment. I'm talking about probably oligometastatic recurrence. Different studies, including ours, which was prospective registers data, showing that probably the best option for this patient is a complementary treatment after a second-line treatment, which could be, of course, the immunotherapy, which is the only recommended regimen in second line and validated prospectively. Otherwise, chemotherapy can be an option. There are several regimens, but no one have been demonstrated improvement over others. So we have 2 to 4 months of median PFS and practically no a durable response with chemotherapy. So IO is, of course, an option. And we have to consider absolutely the multimodality treatment in a multidisciplinary team for probably complementary treatment. That would be the best option.
Yeah. Kristen?
Yes. So we're sort of in this space where we have data in the first line, but not everybody has been treated with IO in the first line yet. So we're still seeing some of these patients who get first line carbotaxol and are immunotherapy naive. So as Stefano mentioned in his part of the talk, there are many options here, right? But we still have to remember contraindications to immunotherapy too, because those can be very important to consider and to not increase toxicity to an unsafe level in these patients. And then, one practical thing is after, say, patients have received months of carbotaxol, there can be neuropathy, there can be cytopenias. So while chemotherapy is it's certainly an option in the second line, if the patient is eligible for immunotherapy, sometimes they're really relieved to be able to go on immunotherapy, which doesn't compound some of the chemotherapy toxicities.
Yeah, I would agree with that. And the only thing to add to that, because we haven't been specific here, is that obviously if this is a patient with synchronous metastatic disease and say they're progressing in their primary, then obviously, it's a very radiosensitive disease. So that would be an opportunity to also use radiotherapy. And as Stefano's also alluded to, if it's just a specific area of oligometastatic disease, ablative therapies, radiotherapies to give the patient a break, as you say, from those chemotherapies can also be quite effective, saving the next systemic treatment for a period of time. So all of those, I think, are potential options. So if you're considering second-line immunotherapy, what patient-specific factors would you take into account? So Stefano.
Yeah, Kristen talked about the contraindication. That will be the first patient-specific factor. And when we see the immunotherapy, they are only a single-arm treatment, so we cannot compare to chemotherapy, and we have no factors to choose between chemo or immunotherapy here. So Availability is important. It's not patient-related factor, but immunotherapy in second line is not available everywhere. And the response, as I showed you, is limited to 10 to 15% of patients. So the best treatment here should be the clinical trial, probably combination treatment, other options. Outside of contraindication to immunotherapy, it should remain as standard treatment today.
Yeah. Anything to add, Christy?
Yeah, those are great points. I think we still have a lot to learn in this area, and there are a lot of opportunities to move the field forward here, especially with other NGS-directed therapies and whatnot too. So certainly clinical trial would be the best answer.
Yeah, I totally agree. And sometimes if you've got someone with a fairly big burden of disease, as you say, sort of with those response rates, you'd be concerned. So that if there are trials, clearly that is a good option. Okay, so they've received carboplatin paclitaxel upon follow-up, so we've got that bit. So then you start the patient on retifanlimab. So how would you plan to counsel your patient on potential adverse events? What adverse events would you monitor for? What monitoring strategies would you employ? Do you want to start, Kristen?
Sure. So I think it's really important to counsel patients, especially starting immunotherapy of any type, on the potential adverse events. Some of them are things that we primarily find in clinical investigation, things like hypothyroidism, et cetera, but some are clinical indicators, diarrhea, dyspnea, rash, et cetera. And so it's, we tend to think of immunotherapy as a very tolerable regimen, and it often is, but there can be very severe toxicities too. So we need to really let the patients know that. And I think also what's very important, because patients and their caregivers may not recognize some of these toxicities as being from immunotherapy. We need to also educate our care teams too. So the nurses answering the patient calls, need to be aware of the different toxicities so that we can work those up and evaluate them and treat them promptly.
Yeah, agreed. Stefano, anything else to add?
I agree completely.
No. Okay. So subsequently, the patient reports an itchy skin rash on retifanlimab. How would you initially assess the dermatological condition, given that this is, if we think the pruritus is determined to be immune-related? How would you manage it? Grade 1 versus grade 2, and let's start with that first. So let's go to that. Skin toxicity.
Yes, skin toxicity is quite frequent toxicity, and especially for patients with long duration under immunotherapy. So fortunately, mostly it's grade 1 or 2, so symptomatic treatment should be enough, but other patients present a higher toxicity, and we have to stop the treatment and start the corticosteroid therapy in these patients. More severe skin toxicity, grade 4, it's fortunately rare with monotherapy at least.
Mm-hmm. Yeah, and I suppose for the two of you, is there, so just talking about specific toxicities, what specific toxicities would you not reinstigate immunotherapy for in this situation? So,
like the contraindications?
Yeah.
Absolutely. Well, certainly prior history of transplant is a big one for me. And then obviously any autoimmune condition that requires systemic therapy. So that can be a little bit tricky, because sometimes patients have ulcerative colitis, but it's been very quiescent. They haven't really needed systemic therapy. So you're weighing the odds, and then, they're getting immunotherapy, and you don't know if it's, what the if patients have diarrhea, what that's from. So it can be a little bit tricky. But it is a case-by-case basis, and it really, for me, depends on the severity of the autoimmune condition potentially, and whether they've been on systemic therapy for it. Those are usually contraindications.
Yeah, okay. And so colitis, we've touched on a bit, but obviously can be quite challenging. How do you generally manage that, and do you have gastroenterologists, and do you have a team sort of, in that situation?
Yes, so that's a great point, because with a lot of these toxicities, we really need to rely also on the assistance of our other specialties. So with skin toxicity, sometimes dermatology can be super helpful. With colitis, GI, for doing flexible sigmoidoscopy and biopsying, so that you really know that this is from immunotherapy, because these can often be very effective drugs, and you don't want to discontinue them, unless you know that there's a good reason to.
Yeah. And between the two of you, can you think of a situation where you've not been able to reintroduce the immunotherapy, and if so, what was it for?
Yes, I think certainly, actually in anal cancer, I've been pretty fortunate. So I can't think of any anal cancer patient that I've had to stop immunotherapy on, which is really nice. It's certainly in other diseases, and there is that interesting difference where, with colon cancer or other, HCC, et cetera, you can see more toxicity. So I don't know if that's been your experience as well.
Very similar, yeah. Not so much in anal cancer, but Stefano?
Yeah, same for me in SCARS trial as well as vaccination trial. We have some toxicity, but mostly grade 1 and 2 and grade 3, and no grade 4 or 5 toxicity.
Yeah, and I think that is really interesting that we're not unfortunately we don't see that. Okay, so this is a 69-year-old male with a history of HIV. So we've got a biopsy showing squamous cell histology, and we've got a large tumor as well as bilobar liver nodule in the leg. So how would you approach first-line treatment? Would you consider biomarker testing prior to selecting therapy? Would you consider new therapeutic combinations? So let's start there. How would you go about that? Either of you?
Okay, so biomarker, definitely. The liquid biopsy is standard in our team, so looking for, HPV, ctDNA, not for the prognosis at the baseline, but to, for the follow-up and treatment decision is quite useful. And, here, carboplatin retifanlimab is definitely a standard option, but we discuss in our committee for potential complementary treatment or resection. And if you need response, probably consider the triplet modified DCF regimen. It's an option.
Yeah.
And then the liquid biopsy can guide us, for resection of these metastatic sites. In fact, this photo comes from one of my patients who had this metastatic remaining after treatment. So liquid with excellent response after immunotherapy in second line, and the liquid biopsy remained positive. So we decided to undergo surgery, and in the surgery specimen, there was remaining tumor cells.
Interesting.
And for the first time after resection, the liquid biopsy became negative, 0 cells in blood. And 4 years later, this patient is free of disease.
Wow.
Impressive.
That's amazing.
Okay. What does it say there? I think we've discussed all that, haven't we? I think we have discussed.
Just maybe with the history of HIV, I'd want to know more about the CD4 count.
About the CD4,
just to see,
exactly,
to make sure.
exactly, and the viral load, etc.
Yeah.
Totally.
What is the cutoff today for daily practice? 200, 300?
Yeah, I usually use 200, but
Okay.
yeah.
200 as well,
Yeah.
Yeah, but it's, but again, this is a situation where I do involve my HIV
Yeah,
colleagues as well.
exactly.
So we treat, but we have good links in
Yep.
with them so that we're monitoring alongside. So assume you're treating a patient with advanced disease who's receiving an immunotherapy regimen and subsequently develops dermatological symptoms that you determine to be a grade 1 pruritus. What is your next step in addressing this AE? Continue immunotherapy, treat with oral antihistamines and topical steroids. Hold immunotherapy, treat with oral antihistamines and topical steroids. Hold immunotherapy, treat with oral antihistamines and IV corticosteroids. Permanently discontinue immunotherapy, treat with oral antihistamines, IV corticosteroids. Consider gabapentinoids. And 5, I'm not sure. So if you can all vote. Okay, so bit of movement. So
getting better.
mainly continue immunotherapy and treat, no, still quite a lot of I'm not sure. Continue immunotherapy, treat with oral antihistamines and topical steroids. Some would hold, okay, and treat with oral. So it's between continuing or holding and treating with oral. I think for a grade 1, I would probably be happy to continue and treat, unless it was something specific that the dermatologist advised us we need to stop for. I don't tend to hold for grade 1, certainly.
Right. Yeah.
I think you probably the same. Okay, so I think this is the recap, but we have sort of covered some of this, or hopefully we've covered all of this. And actually there's some really interesting questions, so I might move to the questions because there's some good questions in here. So, what are treatment options in the third line setting?
No.
Let's start with that.
Okay, good, go.
No, I was just going to say, so, the NCCN guidelines give a lot of ideas in terms of overall, a lot of choices for, in particular, first line and second line. So depending on what they've gotten in the prior lines, I think it's really dependent on that. But oftentimes, outside of clinical trial enrollment, generally go to a different form of chemotherapy that perhaps they haven't had before, as provided they've had immunotherapy, of course.
Yeah, a clinical trial. And then after immunotherapy, chemotherapy is still an option. This is very important to bear in mind. A reintroduction of taxane-based chemotherapy is an option. And we are testing now the combination of methotrexate, doxorubicin, and cisplatin in those patients refractory to previous lines. So probably there will be a phase 3 trial evaluating this regimen compared to FOLFIRI regimen, which is not standard but most used by the clinicians, at least in Europe.
Yeah.
And we have seen, especially in those patients previously exposed in immunotherapy, some long-lasting good response with this all-new combination.
Yeah, and I the same, and I've sent some, actually, we've had some exchanges of some patients with Christophe and with Stefano in France, and it's quite interesting that you can have patients that have relapsed on immunotherapy that then you can give triplet to, or that other regimen of yours. So there seems to be some quite intriguing responses where maybe we're changing the clinality of the disease with what we do, and then you're able to use different regimens. So, but I do agree, ultimately, trials, if we can, clinical trials, because I think that's where we'll get the information from. And if I haven't got a clinical trial, I tend to reach out to our phase 1 drug development team, because again, they often have trials, so which they can also use. So I think, it's an interesting space, and I think there's still a lot we've got to learn. So with new IO options in the guidelines, how do you select between them?
Say that again?
It says with new IO options in the guidelines, how do you select between them?
So I think you go with where the data is. I think as Stefano mentioned, in the second line, we think of the anti-PD-1 antibodies really similarly. So, as he mentioned, the Nivo-IPI study really had showed no benefit to the doublet. So we're still thinking about immunotherapy, anti-PD-1 monotherapy, but often we think that's kind of a class effect.
Yeah, I think that's fair. What would this is tricky, what would be the design of the next phase 3 to treat this? That's a good question.
A very good question. So we still think that triplet DCF has a room here. And when you see the SCARS trial, the control arm with chemotherapy alone did very well. And you can see that 40% of patients have long duration response. And the second is that if you look about the subgroup of patients with high PD-L1 expression, there is clearly a synergic effect with this chemotherapy and immunotherapy. The PFS rate at 2 years was 70% of patients with the combination of chemoimmunotherapy. But we know that this did not benefit the whole population. So we have to look for this subgroup of patients which get higher benefit for the combination when we use the triplet regimen, of course. So this could be a experimental arm.
Yeah, so you want to actually identify that.
Compared to, of course, the actual standard, which is carbopaclitaxel and retifanlimab.
Yeah, fair. And I think sort of where we've got the doublet and the immunotherapy, if they're positive, obviously it's then what we can add to, what we can do to, well, two things. Who are the really, really good responders there versus the progressors? And then how do we enhance the response? And then for patients who are resistant or progress, what do we treat them with? So, but those are all probably not all necessarily one and the same trial. Those are probably different questions that we need to work through. Because I think we have a positive trial, but things like the CPS scores and the PD-L1 and the different scores and sort of depth of response and duration and markers are things that will be helpful. Particularly, for example, I was in Singapore at ESMO Asia, and quite rightly, one of the things pointed out was that obviously immunotherapy is costly and not available everywhere. So it's just thinking about finding ways of identifying patients that are going to really respond. And I think that's work we've got to continue with.
That one might be in the running for the gift card contest, that question. That's a good question.
Yes. Okay. Biomarker assessment. Should you perform NGS for everyone?
Do you guys do NGS on everyone? Out of curiosity?
We don't do we do a limited NGS to start with. So we will always get PD-L1, we will get certain markers. Then if they, as post first line, if we're then trying to understand about trials and things, then we will do NGS.
Sure.
We did it in, as exploratory analysis in the clinical trial. We didn't find very interesting things there. No. So as I said, this is a very homogeneous disease, so mutations PI3Kα, but not very interesting as targeting the disease, and others are, very rare. So I don't know to generalize NGS for all patients. I don't think so, and maybe we should look for other biomarkers. I think.
Yeah, we typically do send NGS on everyone because it's accessible, but you're right, there are not many driver alterations that we find. I was shocked to find that HER2 amplification the other day.
I have found a few HER2, but I would agree with Stefano.
But that you could do by IHC as well.
Otherwise, there's nothing, you see some PI3, but nothing terribly actionable, so it's not that helpful.
Not like in other diseases.
No. Okay, for Dr. Kim, What line of treatment do you choose for first line in patients with brain metastases?
I used to do it's not symptomatic, brain metastasis. I start with triplet chemotherapy, and depending on the response, I design the definitive treatment, along with other metastatic sites or primary tumor. And this is a rare, localization. We have seen a few patients like that, and fortunately, those patients responded to initial chemotherapy. So.
Yeah, okay. Do you think induction therapy with chemo and IO followed by chemo and IMRT may have a role in the future? Certainly that's the subject of some of these trials, isn't it? And I think we all think that potentially bringing the IO into the localized setting may have a role. I suppose it's where. I suppose it's whether it's concomitant, whether it's neoadjuvantly, or whether it's
adjuvantly. Exactly. Yeah, we have a lot to explore there and learn from the data from the trials that have enrolled. That'll be the next couple of years, I think, where we'll have a little bit more data to go on, certainly in the adjuvant space.
And the SWOG trial has already recruited, but it
has completed accrual.
That's adjuvant IO.
Correct, and that's in high-risk patients,
That's in high-risk
mostly
patients,
lymph node positive.
So that data should read out, I suppose,
hopefully
at some point in the next year or so.
Yes.
Yeah. Anything else?
Oh, we just finished our phase 2 neoadjuvant treatment. It's the combination of modified DCF and immunotherapy as induction treatment. Preliminary results were presented in last ASCO GI, and it's very encouraging. We'll see. We will present probably in ESMO this year the final results, but we are very enthusiastic. I can say just like.
And is this is sort of locally recurrent, inoperable, or which group is this?
This is high-risk locally advanced disease, stage 3, so N positive or T4 and 0. We can, liquid biopsy is very prognostic after treatment radiotherapy, and there are several trials, I think 4 trials evaluating the prognostic role of liquid biopsy after chemoradiotherapy. And probably today there are 100 patients and only 2 recurrences if the liquid biopsy is negative.
Yeah, those data are good.
And the interaction trial, the preliminary results show that more than 90% of patients after induction chemoimmunotherapy before radiotherapy have a liquid biopsy negative. So we'll see that it translates to further efficacy results, but it looks like very interesting.
Would you try a second immunotherapy after failure of IO in the first line, or move to chemo?
Second line immunotherapy after first line immunotherapy?
Would you try a second immunotherapy after failure of IO in the first line?
Oh, definitely no.
Not with the anti-PD-1s, yeah. I mean, but this is where maybe some of the newer immunotherapies might have an investigational role.
Exactly, but certainly not at the moment, and even based on the combination data we've seen, that
doesn't look any better.
Seem to be a role. If you stopped immunotherapy following the protocol, in brackets, no progressive disease, and the patient relapses after 18 months, would you consider immunotherapy re-challenge?
So they've stopped the immunotherapy?
They've stopped it as per protocol, they've given it for a duration of time, and then they're saying...
And then they relapse.
Then they relapse, but 18 months later.
Sure.
Yeah?
Yeah.
I would as well. I think that's perfectly reasonable. And is that the questions? Just trying to see if I've missed any out. Oh, is there a role for retifanlimab and radiotherapy for localized disease? Well, I think we sort of covered that. I think potentially yes. The answer to that is, as I said, there are some trials already recruiting with other immunotherapies. There's many, actually. Pembrolizumab, durvalumab, tezolizumab. So the answer to that is yes, potentially. I think it's about being smart as well with these rare cancers about the trials we do, so not necessarily repeating the same trial, but maybe trying to understand what we get from these trials and then complement them is probably the best way forward. And also I think the thing about the radiotherapy trials is components, and just some of those trials in the localized setting have changed lots of things, and therefore you don't know
Then
which
you don't know
component
what
is
contributed.
contributing. So I think it's really important that when we do those trials, we understand the component that actually contributes to the positive or negative aspect of the trial. But I think the answer to that is yes. Future for retifanlimab utility in the surgical setting, concomitant or adjuvant. So I think the group that is interesting is also the persistent or locally recurrent that aren't resectable but that may benefit from combination treatment. And even if you don't get, so in an organ preservation way, are there patients in that group that if you gave treatment to, you either get them to surgery, but obviously the surgery is quite morbid, or could you even avoid surgery in a proportion of patients if you get good complete responses? I mean, it's not everybody, and it's a select group, so I think there's that group that's interesting as well.
Yeah, agree.
And I think that is all the questions, so I'm going to announce the gift card winners, which is very exciting. Right, and I will direct them to Jenny, who's over there to the left. So here we go. It's Federico Estizo. I hope I've said that correctly. $50. I keep saying £50. It's $50. Then we've got, who have we got? Inkle Mona. And then we've got Louis Basbus. So you can all go and get your $50 Amazon gift card.
50 pesos.
I hope this is not a fix. And with that, I would like to say thank you all very much. So please complete and submit your post-test and evaluation. You can download all the slides and the aids, and you can also watch the replay of this event in the next 24 hours and also in the next coming weeks. So thank you very much for joining us, and I hope you enjoyed the session. Thank you very much.